Today's speaker is Robb. I've worked with Andrew now for I think 3 or 4 years. He's a doctoral candidate in computer science. He's going to graduate this summer. He did his bachelor's at the University of Florida, and now he's completing his PhD. And he was the main driving force behind a lot of the virtual human work that has been done at the College of Medicine. And I've asked him to share today with you how we build virtual humans, how we apply them, and I think it will be a very interesting talk. Thank you.
Thank you very much for that introduction, Dr. Lampotang, and thank you all for being here with me today. So as Dr. Lampotang said, my name is Robb. I'm a member of the Virtual Experiences Research Group at the Computer Science Department here at UF. And our specialty, our focus, is using virtual humans for medical education. So I want to talk about 3 things today. We'll start off looking at what exactly is a virtual human, look at some examples of that. We've got an interactive demo, one of our virtual humans, as well as some videos. Then after that, we'll go on to look at a case study of how we've used virtual humans for team training here at UF Health. And then I want to take a little bit of a different approach and start talking about how we actually build our virtual humans. We have lots of collaborations here at the hospital, and we're always interested in expanding those collaborations. So I want to take some time to talk about how we actually build our virtual humans to give you an idea of if our approach could be helpful for any of your projects. We're always interested in other collaborations, other research projects. And there should be plenty of time afterwards for questions, so you're welcome to interrupt me if you'd like some clarification, but also please be thinking of questions for afterwards. So we'll have time for discussion. So first off, what exactly is a virtual human? So when we talk about virtual humans, we basically mean computer programs that look like people, talk like people, and behave like people. That behavior can be high-level behavior like decisions, actions. It also includes low-level behavior like things like gaze and emotion. Virtual humans come in many different shapes and sizes. I like to divide our virtual humans into 2 categories. We have what we call a desktop virtual human. So this is a virtual human that runs on a desktop or a laptop. You usually interact with them in a web browser. You communicate with them by typing to them. So these virtual humans, it's sort of like an instant message program or where you type your question, and the virtual human receives the question, thinks about it, decides how to respond, and you get both text and speech back from the virtual human. One of the biggest technological limitations with virtual humans right now is just speech recognition systems, and that's somewhat outside of our area of expertise. But so we often do things like when you're working with desktop interactions where you can type, we have them type to reduce errors related to speech recognition. Because we can use typing to communicate with these virtual humans, they are fully automated. So you're actually talking to a real computer, which has many benefits. It means they're always available as long as the web server is up and running, which should be 24/7. You can talk to a virtual human. There's very little infrastructure required to set up these exercises. Students can just go and talk to this virtual human whenever is convenient for them. I'd like to give a demo now of one of our virtual humans, just to give you a brief idea of what this sort of interaction looks like. Demos can always be a little cantankerous, so we'll see if it actually works, but I tested it earlier, so we should be able to get it working. So this particular virtual patient is suffering from cranial nerve damage, specifically a cranial nerve 3, which means she's having difficulty with one of her eyes. She's having double vision or blurry vision, and has come to the doctor to try and understand what's going on. So I can start off asking her a question, how she's doing or what brought her in to see me today.
And I'm really worried about it.
So she's having double vision. She's worried about it. I can ask her about if she's had vision problems before. We're typing them here. We do have other interactions where are more menu-driven. So you can have, based on everything the virtual human can say, you can select the questions to ask. But most of our virtual humans, at least that I've worked with, are free-form text entry. So the student actually has to think of the question, figure out what question they want to ask, think how to phrase it, and then type it in. That's a good question, though. We do also have menu-driven virtual humans. So here I'm asking her if she's ever had double vision before.
I've never had any problem with my eyes before.
So she's
I
never
normally have 20/20 vision.
So she's never had problems before. We'll ask one more question. Let's see. Can you tell me more about this, about your double vision?
With both eyes open, I see everything double. It seems like one image is up and to the right of the other. But if I close one eye, the double vision goes away.
So this particular virtual human, we have a lot of virtual humans that have cranial nerve disorders. It's one of our major projects. And we've built, you can also do a physical examination of this virtual patient using virtual tools. So I can give you an example of that. We can hold up a hand and ask her to follow our finger to see how her eyes are tracking.
Okay.
So she'll start to follow my finger, and hopefully you can see it up there, at least in the larger window. One eye is tracking the finger just fine, but the other eye is sort of swollen and gets stuck when we move it past a certain point. So students can use tests like this or other tests that are important to cranial nerve damage so they can get experience practicing these tests in addition to asking the questions. And I'll come back to these cranial nerve patients in a couple minutes. So the other type of virtual humans, so if you remember we were talking about desktop virtual humans. Those are virtual humans that are small, fit on a desktop, laptop, very portable, interact with them in a web browser usually. We also have life-size virtual humans. These are a little more complicated, but they're also a bit more engaging, powerful for training purposes. So with life-size virtual humans, it's actually a life-size virtual human. We have special units that we can wheel into different rooms wherever we're doing training, and you can actually have the virtual human standing in the room with you. You can see them and actually talk to them like you talk to real people. So it's much more immersive. You can see the person. They can look around the room with you, interact to some degree with the room, depending on the quality of the simulation. However, to reach this level of detail or immersion, we have to use what we call a simulation wizard. So this is very similar to when we have patient simulators. Some of the more complicated ones need a simulation engineer who's sitting in the room, controlling the mannequin, making it respond to what students are doing. Because of those limitations of speech recognition technology I mentioned earlier, we use a similar approach when we have these life-size virtual humans. To let people talk to them, we have someone who's sitting behind a curtain controlling the virtual human. The term wizard actually comes from The Wizard of Oz, where he's sitting behind a curtain controlling it. Let's see. So we don't actually have a life-size virtual human here with us today, so I've got a video. Let's see. So some context for this video. This is part of a training exercise where nurses were working to prepare a simulated patient for surgery. So at this point, she's gathering information from the patient's mother that's important before the surgery begins. So when this video starts, you'll see the mother and the virtual anesthesiologist talking to each other, finishing their conversation, and then the nurse will get a chance to ask the mom some questions.
Take anything by mouth or?
I don't know. We've had procedures in the past where they give them a little bit of gas in the operating room to relax them, and then they start whatever they have to do. I'm not usually there, so I don't really know what that is.
Well, we have a nice bubble comfort mask we can have you breathe to help you relax, and then we'll take our IV placement.
That'll be perfect.
Great. Okay, I think our nurse needs to check a few things with you, and then we'll send you back to the operating room and get started.
Thank you. It was nice to meet you.
You can go ahead and ask Molly any questions you need to.
Okay. Good morning, Miss Molly. Could you tell me your son's full name
Clay Matthews.
and his birthday?
April 13th, 1999.
Okay, I'm gonna just take a few minutes to verify his medical record number.
Okay.
1, 2, 3, 4, 5, 6. Okay. And what are we having done today?
He's having scoliosis fixed today.
T1 through L1?
And we'll actually come back to this exercise in a couple minutes. This is taken from that case study we'll be looking at with using virtual humans for team training. So we've used virtual humans for many different simulations, for many different training exercises. I've listed several here just to give you an idea of how diverse virtual humans can be, or how they can be useful in many different situations. We've used them in patient interviewing cases where we have a virtual patient who has dysphagia, swallowing problems, or dyspepsia, stomach issues. We have a wide range of cranial nerve patients, like I showed you earlier. We also have virtual humans for mental health counseling, so virtual patients with bipolar disorder or depression. We can also even do physical exams with virtual patients, like breast exams, prostate exams. There, what we do is we take existing physical exam simulators and merge them with a virtual patient. So you can practice performing the exam on a simulator while also communicating, talking with your patient. So you get both aspects of the exam at the same time. We've done pediatric interviews, working with pediatric patients, as well as lately we've been working with team skills and communication. So why do we actually care about virtual humans? This is important to consider before we start looking at how we're actually using them. I think there's two main arguments for the use of virtual humans. One is that virtual humans can actually open up new opportunities that aren't possible using traditional methods. The cranial nerve patients are really good examples of this. Medical students often get experience performing interviews, learning to ask questions, diagnose things with standardized patients. We have a human actor who tries to portray the illness, gives all the right answers, talks about how they know what problems they're supposed to be having. But when you start working with neurological disorders, it's very hard to fake something like that. A standardized patient can't actually have one of their eyes get stuck and the other eye continue moving unless they actually have the disorder. And that's something that's very easy to address with virtual humans. We can have virtual humans exhibit any symptoms that is necessary to actually learn how to diagnose the disorder. And so now medical students can get hands-on experience seeing what cranial nerve disorders look like, get to actually use the different tools and learn to recognize what the symptoms look like. So virtual humans can open up new opportunities like this where that aren't possible with traditional methods. Virtual humans can also improve or expand upon existing methods. There's at least 3 ways that they can do that. One is you can have much greater availability or greater frequency of interaction when a training program integrates virtual humans. So again, going back to standardized patients, medical students, as I understand it, generally get to interact with them a couple times a semester, depending on the school's program. Whereas with virtual humans, they're online, they can be accessed off of standard equipment. Students can access them anytime they want to, as many times as they want to, if the instructor chooses to give them that freedom. So you can get you have many more opportunities to practice things. Virtual humans also have improved standardization over other methods of training. Again, especially with standardized patients, there are steps taken to standardize the experience, but they sometimes forget a response, ad-lib a response, say something that's incorrect and could be misleading to students. And that's very rarely an issue with virtual humans. With virtual humans, you can sometimes have the virtual human fails to understand the patient or the student and gives a different answer, an answer to a different question, but they'll always be consistent from person to person, unlike standardized patients. Then additionally, it's easy to customize and personalize virtual humans. So if you have a standardized patient who is learned to portray one particular illness, but you want to have people learn to recognize that illness in a different ethnicity or a different weight, if obesity is an important part of this illness, you actually need someone who's that ethnicity or that weight to pick up on those important cues with a standardized patient. But that's very easy, again, to change with a virtual human. Those sorts of characteristics are very easy to modify. Another question, though, is are virtual humans even effective? And this is definitely still an ongoing area of research, but results are very promising that virtual humans are at least as good as existing educational methods. 2 studies in particular have looked at how skills learned with a virtual human transfer to the real world. And then additionally, other researchers have actually compared interactions with virtual humans to interactions with real humans. So in this case, they set up a virtual OSCE and a real OSCE where medical students or medical residents are going through an assessment process. And they looked at how they interviewed virtual patients and interviewed standardized patients. And there was a very strong correlation between how students performed the exams in both cases. So we generally see people behave the same way with real humans and virtual humans, which is important when you're thinking about using virtual humans for training. So now I'd like to move in to talk a little bit about what I'm calling a case study. It's just one instance of an exercise where we've used virtual humans for training, specifically in this case, team training. So team training is important. It teaches people how to operate as part of a team. Teams are very commonplace, very essential to modern medicine. Research has shown team training can lead to improved communication, improved coordination within a team. But unfortunately, team training is often very difficult to get much experience with. Since we are talking about involving lots of people who are usually very busy, you either can't set up training exercises in the first place, or you have a problem where you schedule an exercise and a key team member doesn't show up. You have, say, a surgeon, an anesthesiologist, and a nurse scheduled for an exercise. If the surgeon doesn't show up because he's stuck in surgery, you're not going to be able to move forward with the exercise. So we're exploring a potential solution to this is that we can develop virtual humans to replace those key team members. So again, if we have a virtual surgeon available, we could wheel that virtual surgeon out of the closet, so to speak, and have him replace that human surgeon. So now the training exercise can move forward. So this is the scenario I just described is actually from the exercise we'll be looking at, where we have a nurse working with a surgeon and an anesthesiologist to prepare a patient for surgery. In this case, since we were doing a research study as well, we used human nurses, and then we have virtual surgeons, virtual anesthesiologists, or we have a human surgeon or a human anesthesiologist who's played by a standardized patient. So it's a confederate who's not actually receiving real training. So the goal of this exercise, we call it the speaking up exercise. The goal of this particular exercise was to give nurses experience speaking up about patient safety errors. So a patient safety error occurred, and we wanted to see, would nurses identify it? How would they react to it? So hospitals obviously care a great deal about patient safety. I'm always amazed talking with Dr. Lampotang and other people I work with here at the hospital about how few incidences of errors we actually can occur at a hospital. Coming from a computer science perspective, we would love to have as low an error rate as you sometimes have here at the hospital. But even then, errors, any errors at all, are unacceptable when we're talking about people's safety and people's health. And research has definitely indicated that errors are still ongoing because people are human and they make mistakes. 2 studies in particular recently have identified that up to 4,000 never events occur during surgery each year. These are things like wrong site surgery or an object being left inside of a patient. Other researchers have shown that preventable medical errors contribute up to 200,000 deaths each year. And the focus of this particular exercise was to give nurses experience identifying patient safety errors and giving them experience responding to patient safety errors, speaking up about them to try and prevent them. So the thinking behind this exercise, we were working with nursing management. They helped us identify a training need on their part. The thinking behind it is that speaking up as a nurse can be very challenging. There are many reasons, 2 of which, one is that nurses are often perceived as having less authority, less capability to speak up and stop the team if there's an error occurring. Or nurses themselves sometimes feel like they have less experience and are less qualified to make decisions than other members of the team, even if that's not actually true. And so we wanted to give them experience practicing speaking up to help build confidence. Let's see. So nurses were working with a team of a surgeon and an anesthesiologist to prepare a patient for surgery. They also interviewed the patient's mother, like we saw earlier, to gather important information about the patient. So when they were talking with the patient's mother told the nurse and the anesthesiologist that her son was very sensitive to needles, would get very agitated whenever he was around needles. And so she asked them to wait until after he was induced to draw blood for a type-in screen. The anesthesiologist, the nurse would generally agree to that, and the team would move forward. This issue was mentioned again in the pre-induction briefing. The surgeon okayed it and told the anesthesiologist, make sure you get those samples drawn. And then when you actually got to the pre-incident timeout, however, the anesthesiologist had forgotten to actually draw those samples. And that was the introduction to the patient safety error that occurred. The surgeon, rather than waiting, saying, send the samples and we'll wait to get the results, said, send the samples and we're going to get started immediately. He's arguing there should be time for the samples to get processed and blood to get back before we actually need it. But of course, this is a dangerous practice because the patient could have antibodies, or there could be other complications that would delay type-in screen being completed, or the patient could start bleeding unexpectedly. So it's important to actually have the blood in the room before beginning surgery. And if the nurse would speak up about this, if she identified the patient safety error, in this case, rather than listening to her, the surgeon would dismiss her concerns and argue with her about how it's fine to begin the procedure. And so we're giving nurses the opportunity to speak up about it in a difficult situation. So here I'd like to show a video. This is, you'll see we actually have a human surgeon here. I'll talk about that more in a little bit, why we have human surgeon rather than a virtual surgeon in this particular video. The surgeon here is a Confederate, a standardized patient who's following a script. So this is going to lead up to where the nurse would have the chance to start speaking up to the surgeon.
Okay, you're finally induced. You got your lines in, right?
Yes, you got it.
Okay, so now we've got another one of these two later today. Let's get moving. This is still the correct patient, right?
Yes,
The tag still says Clay Matthews, right?
it does.
His medical record number is still 1, 2, 3, 4, 5, 6.
Yes, sir.
I still see the x-rays over there. I'm still planning to do a multi-level fusion T1 to L1 scoliosis repair. Antibiotics, are we ready to make the incision?
Yes, we're ready to make the incision.
Okay, we have blood available. You sent the specimens down.
We drew the samples, but it looks like they never got sent to the lab.
What, are you kidding me? What have you been doing? You didn't send the samples down?
Look, I'm sorry. They weren't hectic while we're getting ready.
Well, whatever, just send the samples down now. We're going to have to go ahead and proceed while the labs are being processed. We're already running behind today. Any objections?
So the reason we have a human surgeon there is this is part of the research project. The question we were asking is it easier to speak up to a virtual human than it is speaking up to a real human? So we had 26 nurses working with a virtual surgeon and a virtual anesthesiologist, 21 nurses working with a human surgeon and a virtual anesthesiologist, or at least a human actor. And we wanted to see if nurses would speak up differently in these different conditions. It was between subjects, so nurses were only in one condition or the other.
Those that are watching the virtual surgeon, are they aware or did they become aware that there's a
They were not aware before. We talked about it afterwards if they asked.
What was the question? If they were aware that there was a real person they were talking with behind the
Right.
at the time.
Interestingly, in computer science, and correct me if I'm wrong, you always let the participant believe that it's a computer, right?
So this is there's a lot of research. We call this agency, where when we're talking about if something's controlled by a virtual, a computer, or an actual person. And there is research that shows that perceived agency, whether or not you think it's a computer or a human, can change the way you respond. So if we're interested in the virtual agents, so the long-term goal is to get rid of the wizard and it's all automated. So we try to convey that this is an agent.
Which means it's run by a computer, even though it's a human. You hide it. The participant is blind.
Right.
As to, but if they want to assume something, we sort of let them believe it's actually artificial intelligence.
In the case of the human surgeon, did the individuals know each other?
So the question was, did people know the human surgeon? No, they didn't. So this was a standardized patient we hired from the Harold Center, and since if it was a medical student, there's a chance they'd have known the surgeon, but with nurses, no one knew him.
Was that a real nurse?
The nurse was real. The surgeon was not.
Surgeon was not real.
Correct.
He was an actor from the Harold Center, those people who impersonate patients. That's why he's calling him a standardized patient. So we hired him through the Harold Center, and instead of playing a patient, this time he was playing a surgeon.
So did the nurse know that?
No, the nurse did not know.
They thought it was a real surgeon?
We introduced him as the surgeon they'd be working with today. Some nurses afterwards commented on how he clearly wasn't a real surgeon. But
Was it arrogant enough to be?
depended on the nurse you talked to. Some said we hit it pretty well, at least for some surgeons, not all. I was actually, as an aside, I actually was encouraged by how many nurses who said, our surgeons aren't like that usually. So we observed 5 different behaviors. So what we did after the study, we went back and reviewed videos of nurses' interactions with the human surgeon and the virtual surgeon. And we identified 5 different behaviors, or we could classify nurses into 5 different groups, depending on what they've done. This is essentially sort of the outcome to their speaking up, the final thing that's happened. The best result was calling a charge nurse. This was speaking with nursing management. This was essentially the desired behavior, or even you could say the only acceptable behavior in this case. This is the only thing that would ensure the patient's safety, is calling a charge nurse to stop the surgeon. We also saw people which threatened to file an incident report. So here they let the surgeon proceed, but they filed a report about his behavior afterwards. We also saw people shift responsibility to the surgeon. So here they'd speak up, they'd say, I think this is a bad idea. The surgeon would object. And eventually they'd say something along the lines of, I think this is a bad idea, but you're the surgeon, it's your call. You're going to make the decision. And so they're saying, I clearly don't approve of this, but I can't stop you. You're going to be responsible for whatever happens.
Just for my own education, what are the conditions of having to call a charge nurse? Where is the charge nurse? And how's that done? It has to be done pretty much instantaneously,
right,
for it to be effective.
As I understand it, nurses would, in the real world, get on a phone and call the charge nurse who's nearby.
It's actually not supposed to be done instantaneously, focusing on instantaneously. It's supposed to be done as a tiered response. The first response, it's called the CUS protocol. You have to challenge twice before you call the charge nurse. So 3 attempts. The first 2 attempts, you would use the magic words, CUS, it's called the CUS protocol. You would say, Dr. Fischler, I'm concerned because you're breaking protocol. And then you ignore me. I have to give you the benefit of the doubt that you may not have heard me the first time. So I would repeat it. I would say, Dr. Fischler, I'm now uncomfortable because I already asked you not to proceed and you're ignoring me. And then if you keep ignoring me on the 3rd challenge, I say, I don't have a choice now. This is a safety issue. That's the S in CUS, CUS. I'm calling the charge nurse. So you don't do it instantaneously. If you do it instantaneously, by the protocol we were doing, you would also actually be breaking protocol as the nurse, because you don't escalate it immediately. You should escalate it gently until finally you get to the point where you call the charge nurse.
So
I'm sorry.
That's okay.
And during those, from the 1st to the 3rd, is protocol that the surgeon in this case can't proceed, or? Because it kind of sounds like if they ignore them on the first one, then they proceed. I was wondering about just how demanding it is to do this.
So we'll actually see that in a second. But that is an important point. These outcomes occurred usually after a series of negotiation, you could say. So the nurse would usually speak up or communicate to the surgeon 3 or 4 or 5 times before reaching this state. So you'd also have people who give in to the surgeon. They raise concerns, but they either back down, change their mind, or they just stop talking altogether. And the surgeon, they let him have his way. And then the last response we saw was actually people would offer no objections to the surgeon at all. They'd either ask sort of a question, and then when he answers, they just say, okay, that's fine. Or they just say, sure, we can get started. So here I've got a video of someone who's calling a charge nurse. This was one of the the most ideal examples. So this is a nurse who stops the line and calls the charge nurse. Whoop, excuse me.
Okay, we have our over. You sent the specimens down. We choose the samples, but it looks like we're going to go into the lab. What? Are you kidding me? You didn't send the samples down. What were you doing? Well, I'm sorry. You had to. I was reminded. Whatever. Just send the samples down now. We're going to have to go ahead and proceed how the lab is being processed. We're already running behind today. I don't think we should start across the blood in the room. This is a big procedure. Look, Claire's a young man, never had surgery before, never been transfused, and obviously has never been pregnant. So there's what, maybe a 1% chance?
I still don't think we should start at 1%. What if it was your son?
Look, we're at least an hour away from any significant blood loss, maybe even more. The lab should be processed in what, 30 minutes? That's more than enough time.
30 minutes if we're lucky. You know how blood bank works.
So what are we supposed to do for the next hour? Just keep him under anesthesia, getting brain damage for all I know?
No, I don't think we should start the procedure without blood in the room.
You know what? I'm just going to get started. I don't have time to waste. I've got other patients I have to attend to after this kid. Send the blood out, and I'm going to get started. Give me the knife.
I'm going to call my charge nurse and let her know what's going on. We're not comfortable starting.
Fine, you do that.
So here you can see, this nurse negotiated with the surgeon, tried to get him to stop, convince him, made several good points, but the surgeon wouldn't listen. So in the end, he called a charge nurse.
Can you confirm this was a virtual surgeon here?
This was the virtual surgeon.
Right, that's why you don't see the human in the picture.
Mm-hmm.
So the interaction was all very fluid. As you can see, there was no, when we started initially, the was a bit rusty and novice, but now you can see this was back and forth as if it was actually a human in the room. But this was actually the was picking the right pieces of text from a computer screen to respond to the back and forth. And that's why I wanted to bring that, because I think you can easily lose the fact that this was actually a computer talking back. Mm-hmm. Admittedly driven by a human, but still it was a computer. Mm-hmm. And the idea is that when speech recognition becomes robust enough, the was gets replaced by the speech recognition. Mm-hmm. Because essentially, that's what the human is doing. He's doing the speech recognition. And then clicking on prepared pieces of text. And then if you notice, the text was not synthesized speech. It was pre-recorded speech from the same person who acted as a standardized patient, mm-hmm. right? So that's why it appeared as if it was the same guy.
Mm-hmm. So we took steps to try and reduce the variance between the human surgeon and the virtual surgeon. So one thing we did was have the human surgeon record the virtual surgeon's speech, so they sounded the same. So when we actually looked at who did what in the different conditions, we found that people behaved very similarly in both conditions. So here we have the virtual surgeon and the human surgeon, and we're showing percentage of participants who exhibited each behavior. Since we had different numbers of participants, we're showing it as percentages. We saw, most importantly, we saw the same percentage, or very similar percentages, call the charge nurse in both conditions. So we had about 20% of nurses call the charge nurse in both conditions, regardless of if the surgeon was real or virtual. We had a similar number again of the sort of intermediate behaviors, incident reports, shifting responsibility, and giving in. And we did see slightly more people offer no objections to the human surgeon than the virtual surgeon, but there aren't any statistically significant differences between these conditions. And so on the whole, it seems like whether the surgeon is real or virtual has very little influence on what people actually decide to do.
In the last simulation, the nurse was male. Mm-hmm. Did that enter into your analysis at all?
We had, I think, 13 men. We had 69 people go through it altogether. Then 13 of them were men. So we don't have enough numbers to really say clearly. I did look at that, try and include that as a covariate and some tests to see if that had any effect, and it didn't appear to.
The surgeon was always male?
Yes, the surgeon was the same person.
Always male, always white.
male.
So these are obviously covariates we could alter, but because we had such a small study population, so all the study participants were actual nurses. And that the reviewers were actually very complimentary of that, because generally people use psychology students for this kind of studies. But we had nurses who were actually coming from an OR to take part in the study and going back to the OR. So they were really the genuine people we were trying to address. And the location, I don't know whether you know this, that is an actual OR. It's an OR that was no longer used, and Dr. Flynn allowed us to turn it into a simulation OR. So it was totally authentic as far as the environment was concerned.
Sarah?
You said you have 69 nurses. Did you, I must have, if I missed this, I apologize. Did you randomize them to condition?
There was, it wasn't as randomized as we'd like. It was somewhat confined by the schedule of the Confederate. So we had, the Confederate was there at certain time slots, and nurses would randomly sign up for slots based on their own availability.
And do you think that the difference there, if you had a larger sample size, would have been significant? Is there a possibility that difference is looking to me like it might start to be significant?
So one thing that's difficult, it's hard to draw firm conclusions about the no objections part, especially because that is, it's hard to dig into why people had no objections. Some people genuinely thought the surgeon's course of action was okay. We would debrief them about it afterwards. Other nurses, especially I suspect the ones who asked questions, were probably less comfortable with it, but they backed down. So that, unfortunately, it's both the most interesting because there's a large difference, but it's also the hardest to really say for sure. I do suspect, though, that if we have a large enough sample size, we would see that human surgeon is slightly more difficult based on sort of more anecdotal observations. But the main takeaway from this is we see that virtual humans aren't much easier. The concern here, why we were asking this question, is if it's essentially if you have 20% stop the line with a human surgeon, 80% stop the line with a virtual surgeon, it's going to be more difficult to use a virtual surgeon for training because you need to have a certain amount of challenge for it to be useful for people to learn from it.
I'm sort of intrigued by the no objection groups. In the debriefing, did the nurses not realize that there was a reason to object?
Some of it was, I'd say there were two main reasons nurses were okay with it. The larger one was nurses were from a different area, and so they weren't extremely familiar with surgery and didn't realize how big of a blood loss how big of a blood loss risk there could be. So some of it was a knowledge gap, I think. Other nurses were okay with it from essentially being used to bad practices. And so some nurses would say, yeah, this happens in the operating room, and it works out, and so they let it go forward. I do think the larger number of people who were okay with it, it was a knowledge gap problem. This wasn't where they usually work in, and so they weren't unaware of how big of a risk it was with this surgery.
There was actually I'm sorry, you may have said it, if you did interrupt me, but there was also an element where the policy, the hospital policy, was outdated in the sense of, let's say, if I'm getting a mole taken out, do I really need a type and screen? I'm not going to bleed to death if I'm having a mole taken out. So the policy right now seems to be a bit too sweeping, and therefore in that sense it has lost some credibility, because a nurse is saying, I'm getting a mole taken out. Is somebody going to bleed to death from a mole? And do I get into a tussle with the surgeon because he's willing to just go and so what
would blood be set up for that procedure?
Well, according to the way the policy is written right now, you don't proceed until you have the type and screen for any surgery.
For every surgery.
So it's
Right.
pretty broad.
So
That helps the bottom line.
So the beautiful part of that study, in that sense, is you know, Andrew doesn't work in
I understand.
at the hospital. No, what I'm getting to is, so even though he's a total stranger, the simulation provided him a tool to look into the UF health system, and he came back to us and said, you know, this is what the nurses are saying. And then when we ran it by Dr. Burns, who is the chief of surgery, he essentially said the same thing, that the protocol, the policy needs updating, because currently it's too broad, and therefore the nurses think they are on a bit of a shaky ground because it's not logical.
So we also looked at what we call influence tactics. So this is, so if the, what we just looked at was sort of the final outcome, this influence tactic is looking more at what people were doing before they reached that outcome. So it's how they're trying to convince the surgeon. Influence tactics are a framework which has been around since probably the 80s, with looking at basically how people try and convince other people to do what they're looking for. For the sake of time, because I do want to talk about how we build virtual humans, I'm going to move through this quickly. But the main point is two things. Is we saw people use rationality most frequently. Almost everyone used rationality. That's reasoning, logic. And this is what literature shows is the most commonly used tactic. So we're seeing that's holding up with both the human surgeon and the virtual surgeon. The other takeaway from this is we see all the tactics are being used at similar rates with both, again, the human surgeon and the virtual surgeon. That breaks down a little bit when you get to the less frequently used influence tactics, like coalitions and ingratiation. And I'm happy to answer more questions about this at the end when we're in the question section. But again, so this is another view on how we have similar behavior with human surgeons and virtual surgeons. So takeaway points from this particular case study, we see that speaking up is hard. 20% of nurses successfully stop the line, but that's also encouraging in that when I talk to nurses, they would usually guess the number would be around 5%, just because it's hard to do. So Shan's UF Health is not doing a very bad job. The other thing is that we do see is that speaking up to virtual humans and real humans is of comparable difficulty. A human surgeon could be harder than a virtual surgeon. It's hard to say definitively. Anytime you're saying two things are the same, it's very difficult to say that conclusively. But we are seeing that virtual humans aren't significantly easier than real humans, which should make them useful, which could make them useful for training, because people are getting the ability to practice a skill in a difficult setting, and they can build confidence and technical ability. So I want to take a little bit of time. This is going to be a very shallow overview of how we build our virtual humans. My main goal here is to give you an idea of what the process looks like, so you can decide if this is something that could be useful for you, in which case I'm happy to talk or other members of my lab with me. We're always looking for more collaboration opportunities. So we can break our virtual humans down into two sorts of pieces. I'm calling them models and engines. This is an important distinction because when we talk about engines, that's where all the complicated programming is found, and that's thankfully a piece that's very, very reusable. So we've already created those, and they can be reused from one project to the next. So that's not something that our collaborators ever really have to deal with. We work with many people who have no programming experience whatsoever. The other piece, which is what our collaborators work with more, is the model. When we talk about the model, that's the description of how virtual humans should say things. So it's what virtual humans should be talking about and when they should be talking about them. And that is varied from virtual human to virtual human. This is a very simple diagram of what it looks like to build a virtual human. You start out creating this conversation model, a visual model, what the virtual human should look like. We load it up into the engines, and then we test it. And once we test it, we refine it. We find these are the things that the virtual human needs to say that it couldn't say. These are the things that it wasn't understanding. We refine our models, test it again, and keep doing this as an iterative process. And eventually it reaches the point where you're comfortable with it, saying it's doing a good job, and we can start using it in the real world. This iterative cycle of testing and refining is really key to how we build virtual humans. One thing we've learned over the years is that no one no matter how skilled they are, can get it right the first time. And it's just because people are so diverse. I cannot think of everything that everyone else is going to want to ask the virtual human. And so this iterative cycle is really important in building robust virtual humans. So a conversation model is essentially just a database that has a list of everything virtual humans can say and a list of times at which the virtual human should speak. So it's this is customized for every virtual human. Some parts can be reused. So if you think back to that cranial nerve patient I showed you, we have lots of cranial nerve patients and a lot of data about how to build cranial nerve patients. So we can use that to create what we call a template that lets us create new virtual humans rapidly based on that existing knowledge. So if we're creating, if we start to create a lot of the same type of virtual patient, we can bootstrap that with our existing information to do it faster. Probably the best way to really show you what it's like, what a conversation model is to actually show you the interface we use to make them. So we have a website, Virtual People Factory 2.0, which is a second iteration of our system for creating virtual humans. So this is the conversation model for that cranial nerve patient I showed you earlier. And I apologize for this. It's hard to read. It's not very presentation friendly. I can try and zoom in, but I'm not sure if that'll make things any better.
That's better.
Okay. So here, if you can see it, hopefully, there's a list in the center of all the things a virtual human can say. You can scroll up, scroll down. This particular virtual human, I think, can say 188 different speeches. And so the idea is we want to anticipate all the questions that medical students would ask this virtual human, and then create a response for them. So that's one piece of the conversation model. It's everything the virtual human needs to be able to say. The other piece is when a virtual human should say that. So if we take this example, I'm Molly Smith, so she's introducing herself, giving you her name. If we click on that, we have a second list. This is the list of all the things the medical student could ask that should cause Molly to say, I'm Molly Smith. So we have a list of things like, I don't believe I got your name, tell me your name, hi, you are, may I ask your name? So we're trying to think of the ways that a medical student or whoever is being trained might ask the question, what is your name? Thankfully, we don't have to actually come up with every way to phrase it. These are essentially examples that we can do then matching on using some, again, using that engine where we look for similar speeches. So we take what the medical student actually said, we find the example that's most similar, and then have the virtual human give the associated response. This system is online, and we have collaborations here at the hospital. We're happy to open it up for others to use it. So the two big challenges in building virtual humans is anticipating how people will ask the questions. So again, there's lots of ways to ask what's your name, or what problems are you having, are you experiencing pain, whatever question you want to ask. There's lots of ways to phrase that. And so one of the challenges is trying to anticipate how are people going to ask the questions. Because if they ask it in a completely new way, the virtual human can't answer it. And that's part of why we have that iterative process where you really need to get examples of how people are asking these questions. The other challenge is anticipating wrong questions or unexpected questions or unimportant questions. Again, since people who are building the models are usually experts, it's hard to disassociate yourself from your knowledge and the more limited knowledge trainees have. And so when we want virtual humans to respond well, accurately be able to answer questions consistently, we have to really look at what are people going to say, even if they shouldn't be saying that. And so that's sort of underscores another part of this testing. It's important to test with your intended users. So if we're building a virtual patient for medical students, having just experienced clinicians talk to it may not give you very good results because experienced clinicians ask different sorts of questions and same questions in different ways than medical students do. So again, this is just to underscore, building virtual humans is a very iterative process. It's cyclical. Because of this, it can take several months to build a virtual human, but most of that time is not you actually sitting down, typing, working. It's mostly waiting for other people to test it, finding people who tested, getting back to you, and improving on it. With visuals, I'll just say very briefly, we use a system called Autodesk Character Generator to actually generate the appearance of our virtual humans. So it's a very flexible system that can generate a wide variety of virtual humans, and it's very, very user-friendly. So it's easy to say if you need a obese Asian patient for whatever clinical reason, we can generate that in the system. So there's lots of flexibility with controlling what virtual humans look like. Let's see. So the last thing I'll end with is hardware requirements are usually a big question. Does this require really expensive, complicated equipment to run? The answer, thankfully, is no. The virtual humans, like the cranial nerve patients, you can run them on any modern laptop or desktop. It's on a web browser, so it works generally in both Macs and PCs. It's very easy to get students using this. With the Lifesize virtual humans, that's a little more complicated, but really it boils down to this is a TV on a stand with a computer. We've got a Microsoft Kinect attached to it as well. That's essentially, if you're not familiar with it, a fancy camera that not only takes pictures, but also can tell where things are in the room. So we use that to actually tell where people are standing, so the virtual humans can look at them. But these are, it boils down to, again, there's nothing really strange or complicated about it. It's a TV on a stand with a monitor, with a computer. Dave here has had experience building additional ones. He's actually improved on our original designs. So we actually have two in the hospital. If this is important for a project, we can always talk about creating more.
And what's the cost roughly?
This would be under $3,000. Most of the cost is just the TV and the computer. And again, you don't need fancy TVs or fancy computers for this. Okay, so we've got 7 minutes left. I'd like people have questions. I'm happy to answer them.
What exactly were the nurse participants told about the study, and for example, how much knowledge did they have that there were going to be some safety issues?
Good question.
And they were supposed to.
Right. So the question was, did people know that there were going to be safety issues during the study? We did not tell them there were going to be any issues or warn them the surgeon was going to be difficult. We told them that they were here part of the training exercise and they'd be preparing a simulated patient for surgery. Afterwards, we sat down with them and walked them through the test protocol, Dr. Lampotang mentioned earlier, and the 2-challenge rule to try and give them some education about speaking up. And then we actually let them go back and speak up to the surgeon again. So we had to go back so they could practice that. We did make a modification, which makes it hard to sort of gauge learning. We changed the surgeon so he actually would back down after they'd spoken up to him a couple times. Our goal there was to give it leave people with a positive impression, reinforce the training, what they've just been told is effective, and they were able to convince them otherwise.
The training was mandatory. Taking part in the study was not mandatory, but the training, the nursing management had seen some of the work that had been done previously in the PACU, and they made the decision that this was important. So the nurses didn't have a choice about taking part in the training, but they had a choice in saying, I don't want to be videotaped, I don't want to give consent. And IRS office was making sure we were following the rules. And then if they didn't, there was no consequence, they just didn't get a coffee voucher. The coffee voucher was the incentive to take part in the study.
We also reinforced that this was not used for evaluative purposes. We said no one in nursing management is going to see it unless you give permission later. We're not. This is just for you to gain experience. There's no evaluation components as well.
The College of Dentistry uses an extra credit assignment for an emergency dental patient on the desktop interviewed, and that was just this year migrated over to the Virtual People Factory 2. And one other opportunity it provided for us in training, and we're looking at all the data now because it was just an assignment this past semester, but there were opportunities in the Virtual Patient 2 to look at empathetic opportunities, and this is a patient that was there presenting in pain. So there were two, as we looked at our competencies for dental graduates, what were the two empathetic opportunities, and then how were the responses done? So that provided some level of information for us as we look at assessment for accreditation and competencies, where we might be able to build some of that in the early training.
Thank you for mentioning that. That's a project of another grad student in the lab. One thing we do have a lot of emphasis in a lot of projects is empathy, trying to gauge, do people show empathy to virtual humans, which it looks like some people do at least. It might be that people who show empathy to real people also show it to virtual humans. But also to give people training, reflection, trying to cultivate a sense of empathy.
And to elaborate on the empathy part, there was a version of the virtual human with optical nerve damage, where the participant was able to wear a head-mounted display and see the blood, experience the blood vision, right? And then they were not prompted. They look at what the participant did, and the percentage of participants who asked the patient who is driving you home became significantly larger, I think threefold or fourfold. Because before that, even though clearly the guy said, I'm having double vision, nobody asked who is driving you home, or very few asked who is driving you home, because they could empathize with the fact that this person shouldn't drive, because that double vision was pretty bad. But when they were able to wear the head-mounted display and experience it, the number significantly either double or triple or quadruple. So that was, to me, fascinating, because they were not prompted. Spontaneously, they then asked who is driving you home.
I was wondering, are there any processes in place to use the virtual simulation for medication errors, patient safety, medication safety, and or transfer of care when it gets to be a standardized procedure to put this in virtual, so that you can educate so many people to follow the standard transfer of care, because those are two huge things that are definite patient safety related things that we were working on, but I just didn't know if simulation had been involved in that at this point. Probably have been, and I'm just not aware of it, but those are great opportunities.
We had one of our first projects actually using team training was in PACU, and there we actually had a medication error, and so we were looking at essentially closed-loop communication. Would people be listening to the nurse when she responded with what drug she was administering, how much, the virtual nurse, and catch when there was a mistake?
But we have them, people picking up a medication and just giving it, not looking at it, not reading it, and just those are can lead to very detrimental effects with the patient if they're given the wrong medication. They're given rocuronium before they're really put to sleep, kind of thing. And it's you know. So what would you do if somebody picked up the wrong syringe and gave it to the patient, and it's like he stepped in and go, oh my gosh, okay, so this would be a great opportunity to teach. And then communicate with other physicians that this is what has happened, how, and all those. I can just see so much that would be great.
I'll handle this one. So Dan Skorupski has been talking to us about it. The issue, as always, is funding and time. So apparently this has been bubbling up, the medication error and ROR. It is bubbling up to the top of the list. The issue is really manpower and time. As you can see, this is applicable to many of those instances where human error occurs. It all comes down to time and money.
Do you know, is there a simulation, a fully complete sort of physical exam template where people could go in and do physical exam from head to toe? Does that exist in the sim world?
Dr. Lampotang, are you aware of that?
You mean in a single unit, or you can make multiple units together and then have a whole station, a multiple stations?
Just, well, you know, we run the Board of Care, so we assess physician competency here for people who are in trouble with the Board of Medicine. And one of our most frequent finding is that practitioners have let their physical exam skills sort of go to the lowest common denominator. And there are, as far as I'm aware, unless it's changed in the last year or so, there's no CME providing physical exam refresher courses that you can send somebody to. Now, occasionally we've sent people to the Herald Center if there were specific, you know, like they haven't done a prostate exam in so long that they need to go do that piece. But, you know, that whole skill set is, you know, not really available. So we have a need to remediate people, but we don't really have a good mechanism. These people from all over the country. So it seems like as if in your virtual patient there was a complete physical exam, it would be a CME providing and might be a revenue generator.
I think the answer to that is, I'm not aware of one single mannequin that does all the physical exams, but I'm aware of bits and pieces that can be put together. And I think most participants don't have a problem with that if I say, here's the head here, here's the back here, here's the rectum here. They've already done work on prostate simulators and also breast palpation simulators. So these two pieces at least I know already exist.
Right.
And the prostate, they bought it off the shelf. But then what they did is they instrumented their virtual stuff on top. I think it was the same for the breast exam simulator. You bought something,
the
right?
breast was a little bit more custom, but the actual breast with the lumps was bought off the shelf, and we
Right.
attached it to it.
Yeah, because people have spent a lot of time developing those lumps and masses and all that. So they didn't invent that, they bought it off the shelf. So to answer your question, I think if there's a big need, we certainly could go and look on the internet what's available, acquire all those pieces and put together not one seamless human, but different stations where you would do all the physical exams, yes.
We have a life-size cardiology patient simulator that presents all the physical findings of about 30 different cardiovascular conditions, congenital and acquired, that is easily adaptable to both teaching and evaluation.
Right. Yeah, we've used that before. It's just, in general, I've not been able to find a complete sort of course where you can send somebody who's, again, sort of let their skills go and say, we need you to complete this as part of the remediation process. And, you know, there's some medical school videos that you can review, but there's nothing that really tests for, you know, so you don't really get what you need out of trying to get people to spool back up their skills.
And I think the beauty of what Andrew's lab did is you instrumented that breast, didn't you?
Yes.
So they could tell how hard you were pushing, whether you were pushing with the right amount of force. Because it's one thing to say push, but you need to push with a certain amount of force. And they actually were able to determine if you were using the right amount of force. So they quantified that off-the-shelf simulator.
We could give feedback both to instructors and the students.
So I think it can be done. It's just, do you have enough volume to the investment of time and money into that system?
You know, I would think if you want to evaluate a practitioner's ability to do physical examination, you bring them there and assign them to a clinic and have them be proctored by someone who is in the field or doing whatever it is that you want to evaluate.
Well, we do that now. I mean, our assessment is the Herald Center, so we use standardized patients and have them do
Well, I was thinking of
scenarios.
using real patients. Have somebody come from the clinic and act and be proctored.
But then you have to do
Real-life
credentialing and
situation.
all of that, so it gets to be,
It's doable.
yeah.
I mean, I've had a resident in my clinic who was failed the boards and was coming around because of several board failures to get retrained.
Right.
That individual had to go through a succession of pediatric clinics, and came to my clinic for the same purpose. And I had to supervise the residents about history and physical exam skills. And I think it's not an expensive way to do it, because, I mean, it doesn't cost anybody anything to have me do that. Because I do it, because it's part of what I do as a faculty member.
I think there are some IRB issues probably nowadays with this approach. Wouldn't there be?
Well, no more than having a student work with me.
Well, their bigger issue is credentialing and having access to patients. That's the bigger, or whether you come in as a volunteer or those kinds of things. And, most of our clients don't have active licenses because they're in trouble with the board. So then they're not a credentialed person. And so it gets at a lot of issues. It's not, and when you talk about, that's the whole issue of re-entry.
Yeah, well, and then you're also dealing with catch as catch can. So maybe then, let's assume we can do it. But then he sees a patient who has a normal breast, no tumor, no masses. Then what can you say about their skills at that point when, there's nothing? Whereas with a simulator, there are...
I wasn't saying this was necessarily a total replacement. I said it's a one way of evaluating an individual's clinical skills is to put them in a real-life situation.
Any other questions? Thank you for attending. I know that was a great presentation. Thank you.
My pleasure.
I really enjoyed it. I know about it. I even learned something. If you can, please share your reviews with us.
Thanks for telling me about it. I appreciate it.
Oh, thank you.
Without your email, I wouldn't have known.
Yeah. I need to make my email more conspicuous.
Well, I saw it. That's why I'm here, because I got your email.
Yeah, you mean the one to the lister or the one I sent directly to you?
Well, I don't know. It came
two different lists.
Yeah, I sent one on purpose to you.
Yeah, right.
The one that I sent to the lister, people are not seeing it, or it didn't come, or people have it on
That one did not come.
They must have it on the